So here we're going to understand multifocal atrial tachycardia, which can also be referred to as MAT, M-A-T. Now, this is another arrhythmia. Previously, we went over two other arrhythmias, atrial flutter and atrial fibrillation, and we'll see a compare and contrast at the end of this video of the two ECGs. Now, multifocal atrial tachycardia, MAT, it is another arrhythmia, and once again, arrhythmias are when we have an abnormal heart rhythm. And MAT is caused by ectopic foci. So if we look at normal heartbeat, normal sinus rhythm, that initial signal that causes the heart to contract is coming from the SA node, the sinoatrial node. Now, when it sends off that signal, it causes the atria to contract in a synchronous manner, and then that signal is sent off to the AV node, the atrioventricular node, and then there is the brief delay at the AV node because it has a longer refractory period. After that, that signal is passed on to the bundle of His, the bundle branches, and then the Purkinje fibers, causing the ventricles to now contract in a synchronous manner. So that's normal heartbeat. But when we talk about MAT, it's caused by ectopic foci. So essentially, we have other cells in the myocardium, specifically in the upper chambers, the atria, which are essentially backup pacemaker cells if when the sinoatrial node is not working. But what happens in MAT is that we have increased automaticity, and that increased automaticity, essentially, it accelerates the generation of action potentials, thus why we say it's increased. But automaticity can be normal or it can be abnormal. When automaticity is abnormal, that is when MAT is going to occur, because we have these cells that are located in the myocardium, they're the ectopic foci, and they are sending out these action potentials, accelerated action potentials. So MAT is due to abnormal automaticity. One thing we have to clarify quickly is that when I refer to ectopic essentially means in an abnormal location. So the normal location for the electrical impulse to be generated would be the SA node. But now that we have abnormal locations sending off signals, we refer to them as ectopic foci. Now going back over here, so it's caused by ectopic foci, there's increased automaticity, so we have accelerated generation of action potentials, and we're going to see an increased ventricular rate of more than 100 beats per minute. Now, what's different between MAT and AFib, in AFib we saw that we had atrial fibrillation, we had so many signals within that atrium that not all of the signals were passed on to the ventricles because of that brief delay at the AV node. But in MAT, all of those signals generated in the atria are going to be conducted to the ventricles. And what we'll also see is that when we talk about in ECG, the QRS complex, it represents the ventricular contraction, and each ventricular contraction will be preceded by a P wave generating the atrial contraction. So we're going to see that in our ECG for MAT in just a second. But to quickly go over some other key points, the rhythm itself is benign, and it's caused by an underlying health condition. So once we treat that underlying health concern, we can go back to a normal sinus rhythm and recover from MAT. Another key distinction between MAT and the other arrhythmias that we have previously discussed, like atrial fibrillation and atrial flutter, is that MAT will have an isoelectric baseline between the P waves, which we did not see at all in atrial fibrillation. And then we're going to have varying intervals between the PP, PR, and RR. And then also, MAT is most commonly seen in patients with severe COPD or congestive heart failure. So this is common with people who have underlying lung respiratory conditions. Now going back and looking at our ECG, we can see that this is representative of MAT, multifocal atrial tachycardia. And the first thing that we went over is that it has P waves with multiple morphologies. Why is that the case? Well, we have to understand that if we have various ectopic foci, we have different locations sending off different signals, each signal will result in a variable contraction because each signal is sending off a variable action potential of varying strengths, and then the atrial will contract differently, and we'll see that on our ECG. So we'll have different morphologies for the P waves, and those different morphologies are representative of the variable locations sending off signals. And the rule of thumb to diagnose MAT on an ECG is that we must have at least 3 different P wave morphologies present, and each P waves will have a QRS complex right after it. And then also we have the intervals will be varying. So since the ectopic foci, they're sending off signals randomly, rapidly, it's going to cause the atria and ventricles to contract in a more rapid manner. And we'll see that the distance between the P waves and the QRS complexes will be of varying degrees. Now, to compare and contrast with normal sinus rhythm and then the two other arrhythmias that we went over, this is a normal sinus rhythm. We can see that we have our QRS complex. The P wave morphology is consistent. The intervals are consistent. But when we talked about AFib, it had this wave quivering like motion, and we can see that there is no distinct P wave morphology, and there's no isoelectric baseline that is readily visible. Now, this is because the atria are contracting so quickly. Remember, it was 400 to 600 beats per minute. So the heart is essentially quivering, or it's fibrillating. And then in atrial flutter, we had this saw-like structure denoting the P waves. The P waves essentially denote the atria are not fully contracting. As a result, there we see this wave-like motion, and we see consistent irregularly spaced QRS complexes. And then in multifocal atrial tachycardia, we have those P waves. We have visible P waves, but they're of different morphologies because we have those ectopic foci sending off the signals of varying signals. And we have also, once again, we have intervals, we have inconsistent intervals between the QRS complex and the P waves. So that is essentially multifocal atrial tachycardia. It is, once again, an arrhythmia, and it's caused by ectopic foci. And we can, it's a benign rhythm, and it's caused by an underlying health concern, most commonly respiratory concerns.